Can you hold this for a sec? It's not on. Oh, there it is. Thank you. Thank you so much, Ryan. So today I am going to be talking to you about part of my PhD thesis and part of the case crossover study and some of our first findings. And so what I'm going to be talking about today is about some of what we're seeing about the child bicyclists from our study, where they were getting injured on our roads, and some built environment risk factors that we are starting to see. And I do want to acknowledge the huge number of co-investigators and everyone involved in this project as well. Oh, I have to use the clicker. Maybe, there we go. Alrighty, so bicycling, widely acknowledged to be very beneficial for our children, respect to physical, mental health. And what we know is that these physically active habits that are developed during childhood often continue into their adulthood and can have those long-lasting health impacts. So bicycling as a form of physical activity has been shown to benefit our environment, the economy, and can contribute to fostering and improving our communities. Unfortunately, despite all of these recognized benefits, we are seeing an ongoing decline over the past few decades in child bicyclist participation. Previous studies that have explored this have really noticed that one of the key concerns and barriers to participation has to do with traffic-related injury and safety. And unfortunately, these concerns are founded. Can everyone hear? There's like feedback. Okay, can you still hear me there? Perfect. Going to get in my head. Whew, there we go. Alrighty. So unfortunately, despite what I just mentioned about bicycling being an extremely healthy behavior, it can result in a significant number of injuries for children. And they are the leading cause of sport and recreation injury in children. And it's a little difficult to see on the figure there, but what the second one there is ice hockey. So what you can see is that it really is comparable to other high collision sports such as hockey. And so they are a leading cause of emergency department visits, hospitalizations, and deaths, with many of these injuries occurring on road. This is particularly concerning when we think about the fact that there is a fourfold increase in severe child bicycling injury risk when there is motor vehicle involvement. So it's very clear we need to start exploring different avenues and prevention strategies to address these, to hopefully create safer spaces for children to bicycle. And one of these that we explore in my study is modifications to the built environment. So previous research has demonstrated that bicycle-specific infrastructure, such as physically separated bicycle lanes, can reduce bicycling injury risk in adults. However, very little research has been done in children, and it's really important that we determine those child-specific built environment associations, given that children do interact with their environment very differently than adults. So some of this work that I'll be presenting today is based on some seminal work that was done by Kay Teschke, which used a case crossover study and in adults, and we have now applied to the child. So the objectives of this study were first to assess where child bicyclists are getting injured in 3 Canadian cities. And second is to compare the presence of different built environment features at injury locations to control locations along the injured child's route. So to do so, as I mentioned, this study is using a case crossover design. And what that means is that each child not only contributes their injury location as their case, but they also contribute 2 additional control sites from along their injury route. And what this really neat methodology means is that comparisons from cases and controls are not only within child, but also within trip. And so what this approach allows us to do is to overcome some previous methodological limitations of bicycling injury research by controlling for some of that variability within trip and participant characteristics. So what did we do? We recruited injured child bicyclists aged 5 to 17 who presented to one of 3 participating children's hospitals in Canada, the BC Children's Hospital, the Alberta Children's Hospital, and Toronto Sick Kids. We began data collection in May 2018 and concluded in October 2021. So we went for 4 years, 3 emergency departments, a pretty large Canada-wide study, and we ended with a sample size of 342. And this was all done in collaboration with the pediatric emergency research teams in the emergency departments across Canada. So once the child presented to the emergency department, they were screened for eligibility. And our eligibility really made sure that the emphasis was placed on bicycling for physical activity, active transportation, and the built environment in major urban centers. So that meant mountain biking, trick riding, racing, other form tricycles were not eligible for our study. So once the participants were recruited, participation involved a 30 to 45-minute semi-structured interview with the injured bicyclist. And the primary goal of these interviews really was to determine the exact location where the child bicyclist was injured, as well as their route that led to the injury. We also asked them other questions about injury circumstances, the environment that was at their injury and control sites, as well as additional personal information. And these interviews really were a lot of fun. We engaged with the children a lot. So you can see here a nice drawing that a child has done that recreated their injury event. And they have even added kindly the concept of time in there for us to let us know. So it very much was a fun, engaging experience for the children. Once we got their injury route, we took the case and control sites from each child and they were given to a trained auditor for a structured and objective in-person site audit. These auditors were blinded to the site's injury or control status, which helped us address some concerns about bias there. And during these audits, we went out and collected detailed information about the infrastructure present, traffic speed, volume, type of route, grade, service quality, visibility, presence of traffic calming devices. So it really was a very thorough, structured site audit. So what did we see? So in our sample of 342, you can see here the breakdown from the 3 cities. So in Vancouver, we had 138 children, Calgary 79, and Toronto 125. And of our participants, 70% did self-identify as male and had a mean age of 10.6. So for our first objective, getting to the meat here, we were really looking to assess where children were getting injured while bicycling. And what we can see from this first side here is that most children were getting injured on road. So that includes the road component and the intersection. For those specifically on road, the majority occurred on local streets, meaning streets without a marked lane. And you can see here a bit of the distribution along those other ones. So 14% also at collector or minor arterials, 12% along major arterials. And then when looking at the broader route type, we can see that 20% of our participants were injured on a sidewalk with a similar proportion on a multi-use path. And you can see that other breakdown there of just exactly the environments that children are going and where they are getting injured. So specifically for those injuries that occurred at an intersection, 60% occurred at a 4-way intersection, followed by 38% at a 3-way intersection. The remaining occurred at a roundabout or traffic circle. I am currently going through the photos to correctly differentiate between those two. So we will have that data shortly. And then of those, 88% had some sort of control present, such as a stop sign, yield sign, or lights present at the intersection. So next up, we ended up and we compared our injury and control locations. So when we compare those, you can see that injury locations had fewer bike signs and symbols that were visible from their site and had slightly less bicycle infrastructure present. We also looked at whether the child was physically separated from the road. So that's a median, bollard, something physical separating them, and which occurred at 23% of the injury locations and 30% of the control locations. Of interest, construction was also present at many more injury sites than control sites as well. So please take into account all of these comparisons are unmatched. So they don't account for the fact that the same child is contributing both case and control sites. And that comes next. So what we did is with these same variables, we did a preliminary matched case control analysis where we can see here that having bicycle signs and symbols visible was protective for bicycling injury. And having bicycling infrastructure present was not statistically significant. Again, this is preliminary, and our further model we might see something different there, depending on what road it was, if we stratify there. Being physically separated from the road was also protective against child bicycling injury, which is really an important finding of this. However, presence of construction was a risk factor for injury with an odds of 2.89. So a few other variables that we looked at included debris, and within that category, specifically gravel. And you can see here the different breakdown. Debris was present in almost 60% of the injury locations compared to 46% at our control locations. We also looked at traveling downhill, as well as whether or not the surface where the child was injured was smooth, or if it had bumps present or any potholes there. And what we can see is that for all of these variables, there was a larger proportion present at injury sites when compared to these control sites. Again, this is our unmatched comparison. And once again, once we take into account that matching for those same variables, you can see here that all of these were identified as risk factors with odds ratios of 2 or more, and they are all statistically significant. So presence of debris had an odds ratio of 2. Presence of gravel, 3.36. And for those who were at my talk on Sunday, these were all variables that children were also identifying from a qualitative standpoint, which is really neat as well. So children are aware of these risk factors that they're facing. Bicycling on a downhill grade compared to a flat grade had an odds ratio of 3.4, and a bumpy surface compared to a smooth surface had an OR of 2.14. So with that, what did we find? Preliminary findings really are suggesting that many of the child bicyclist injuries that we're seeing are occurring on local streets, local roads, and maybe we need additional infrastructure there. We need to explore that further. Specifically, presence of bicycling specific signs and symbols and physical separation from the road may be protective for child bicyclist injuries, particularly that physical separation from the road. I do want to point out that was not a painted line. That was a physical separation from the road there, as well as presence of debris, gravel, surface with bumps, and traveling on a downhill grade may additionally be risk factors for child bicyclist injuries. So with this, one of the next steps that we will be doing is with that case crossover, we almost have a sense of repeated measures within the child. So we are going to be using a mixed effects logistic regression next to account for some of a bit more of the matched data that comes from using injury and control data from the same child. And that will be coming out hopefully in the next year or so to share that data there. And what we hope to do with some of this information is to better understand where injuries are occurring, risk factors, so we can inform those key stakeholders at different levels as we are developing policy and interventions to not only decrease child bicyclist injury, but also create safer spaces for children who want to be physically active and encourage that participation. So with that, before we get to questions, I do want to quickly acknowledge all of our incredible team of collaborators, researchers at different sites who are contributing to this project, as well as the CHASE team, which the bike study is part of. So with that, thank you very much, and I will open the floor to questions. Yes.
You mentioned built environment infrastructure didn't have a significant effect. And I just want to understand, like, because I know you said physical separation, you talked about the signage and symbols, but what did you mean by that built environment
So
infrastructure?
infrastructure could have been a bicycle specific track, a bike lane present. There was a whole multitude. We created a dichotomous variable with a whole bunch of possible infrastructure features that could have been present there. So it went beyond just signs, sharrows, symbols, to specifically bike lanes, bike specific, at crosswalks, was there bike specific features there for crossing for bicycles. So it included that. Part of what we think might be going on there is for the control sites that I presented in the matched analysis, we were only able to use one of our control sites for the matched case control analysis. But in the mixed effects logistic regression, what it's going to allow us to do is to take both control sites to increase our power in that model. So we might actually be able to see a bit more there. And then with that bicycle infrastructure, we are going to look at whether bicycle infrastructure has a different impact on different road types. So does bicycle infrastructure have a protective effect on local streets compared to major streets? And we'll be integrating it more into that. So that I'll say is very preliminary. We need to explore that more, but yes, great question. Other questions? If not, you're welcome to contact me. Please feel free to reach out. I'm more than happy to chat about any of this research afterwards over email or in person. Awesome. Thank you so much.
Thank you very much, Janet. Give this to you. Sorry, on behalf of the cards. Thank you very much. As I quickly access my phone here. Our next presenter is going to be Dr. Sarah Redmond. Dr. Redmond is an injury prevention lead at Public Health Ontario, as well as an assistant professor at the Division of Epidemiology, Dalla School of Public Health at the University of Toronto. Sarah is an injury epidemiologist and a certified exercise physiologist with doctoral and postdoctoral training in injury prevention with expertise in injury epidemiology, implementation science, and knowledge translation. Please help me welcome Dr. Redmond. Thank you.
It's not working. It's there. There. Are you sure? Thank you. Sorry about that. So thanks for that introduction. I'm so sorry, but my last name is Richmond. um, Thank you for the introduction, and thank you for the opportunity to share with you some resources that I had the opportunity to co-create. Janet, what's the trick? Oh, thank you. Ta-da. So I'm presenting on behalf of the Chase team, and Janet presented some work related to Chase. I'm sure you've seen several Chase presentations at this conference, as well as the last CARS conference as well. If you haven't heard of Chase, Chase is a federally funded multi-sectoral team of researchers and stakeholders that include practitioners and advocates for road safety. The Chase team research focuses on active and safe travel for children and youth in the context of the built environment. The research broadly has three objectives. The first is around determinants of active transportation, or better understanding what are determinants of active transportation. The second around safety and how safety is associated with active transportation in the context of motor vehicle collisions. And the third, which I had the opportunity to co-lead with Dr. Alison McPherson, is around how do we support local practitioners to do the work associated with the built environment and to incorporate the built environment planning into their programs of public health. So what I hope to cover in the next 15 minutes or so is a little bit about road safety in the context of public health. And then to share a little bit about the methods, I'll go very quickly over the methods for the development of each of these resources, to show you the resources themselves, and then to present some of the challenges in doing this work. So typically, public health practitioners influence population health by addressing road safety through education. A lot of practitioners locally in Ontario do a lot of advocacy for road safety through awareness campaigns and educational campaigns. However, another role recently played by public health practitioners, and one that I'm starting to learn more about in my time at Public Health Ontario, is they advocate for effective engineering changes. So the sort of the 3 E's of injury prevention, shifting away from education and more toward advocacy around supporting built environment changes. So what we mean is physical changes to the built environment to support road safety. So from a policy perspective, of course, understanding the evidence and how effective built environment interventions are in the context of motor vehicle collision prevention would be very helpful to public health practitioners, as well as those in road safety. However, both public health and built environment practitioners cite the lack of accessible resources, including evidence summaries and local data, is a significant barrier to their practice. So when they build programs of public health, they often tell us that they don't have evidence summaries available to them. They don't have time to be able to access the scientific literature themselves. And having that kind of evidence summarized for them would be very helpful and to help them overcome that as a significant barrier. They did cite access to local collision data specifically. So these are public health practitioners, not transport planners, as a very significant barrier to development of their work. So the objective of this work was to develop resources for road safety practitioners to inform their program of public health. So I'll be showing two resources today that we helped co-create. One is an online resource that summarizes the effectiveness of built environment interventions. And the second is a series of infographics. And these infographics were developed for each of the municipalities that are participating in the CHASE study. So this is a slide about the methods and a very high level sort of summary of the methods. But what I really wanted to emphasize here before getting into specific information on how we develop these resources was the fact that the iterative consultation process that we had with our stakeholders and end users was really important to this process. So this is for the website, which is called projectchase.ca. So we completed an environmental scan of road safety policies that were implemented in the 5 municipalities participating in CHASE. So that's Toronto, Peel, Calgary, Vancouver, and Montreal. So we retrieved the built environment interventions that were embedded within those road safety policies and tried to find the scientific literature to support looking at the effectiveness of those interventions. So for the literature search, we did both a peer-reviewed and gray literature search. And we had 2 independent reviewers that looked at both peer-reviewed and gray sources that included Medline, PubMed, and Google Scholar. We used search terms for both literature searches that included road safety, built environment, motor vehicle collisions, policy, and intervention. We included studies that examined a built environment intervention that had to have a collision or a collision pathway outcome. And what I mean by that is vehicle speed, vehicle volume, or yielding, for example. We included any study design in our literature search, but limited our search to studies that were published in the last 20 years. We excluded studies that were not built environment interventions, so those that did not look at the effectiveness of the intervention itself. And we excluded implementation or planning guides, as well as those that looked at modal choice or information specific to physical activity. So we used a critical appraisal process for all of the studies that were included in the online platform. And of course, we used tools, critical appraisal tools that were specific to the study design. So we used the trend checklist for quasi-experimental studies, the Axis tool for cross-sectional studies. We use CAS for both case control and cohort studies, and we use the health evidence tool for systematic reviews and meta-analyses. The critical appraisal scores were divided into 3 equal categories based on their scores, and we borrowed some guidance from health evidence to categorize them as weak, moderate, or strong. So data from all of the studies that were retrieved for the literature search and the critical appraisal process were synthesized by intervention type. So we took all of the information out of the studies and extracted it from each and then categorized them based on their intervention type. So we categorized them as bicycle interventions, vehicle interventions, or pedestrian interventions. To develop the tool itself, so we had all this information from all of the studies and we wanted to sort of translate all of that information into an accessible resource. So to do that and to develop the tool, we first completed a series of key informant interviews. And so that included the stakeholders and end users that were part of the CHASE team, as well as those that were participating from each of the municipalities. And we asked them all sorts of questions. So what should this tool look like? What information should be contained in the tool? How should we present the information? What information should be presented from each of the studies? And we did that through a consultation process throughout the entire tool development. The stakeholders included transport planners, public health practitioners, researchers, and transport engineers. So the final product was developed by the digital design team at the University of British Columbia, and they are experts in online content creation. So there was a total of 118 studies that were retrieved from the literature review part of the environmental scan, and 48 interventions in total were included in the tool. So we have 10 that are associated with bicycle interventions, 26 for vehicles, and 12 for pedestrians. So this is a screenshot of the tool itself. And I'm hoping that I can link out to show you what the tool looks like. Uh-oh. I disconnected from the, I apologize. Oh, it is on the screen. So this is the website. I'll go back to it so we can just leave it for this part, yeah. So this is the website itself. So this is the landing page, and you can see it's divided into bicycle interventions, vehicle interventions, and pedestrian interventions at the bottom. There's information on how to use the tool. So you can sort of do a little bit of a read on the methods that we applied on retrieving all of the articles and the information contained in the tool. There's also, methods on the critical appraisal process and how we included studies. There's a section on how to interpret the effect estimates that are presented within each of the interventions, as well as whether or not that intervention can be found in the TAC manual. We also give a little bit of guidance on how to interpret the results. So we put the interpretation sort of in context of the intervention itself, coming from the summary of evidence that's provided for each intervention. So I'll just do a really quick navigation of one of the interventions. So this is the integrated a bicycle integrated roundabout. So you can see there's a little GIF that shows how the intervention itself works. There's also a bit of a description here on what we mean or how we operationalize and define that intervention. The study designs that were included in the summary of evidence, how they rated on the quality of the reporting of the study, so the critical appraisal process, again, the interpretation of the estimates that are in the summary of evidence, and then the actual data itself. So the user can navigate through intervention types here at the side, and they can also link out to getting that more information. We've also included an evaluation or a survey in order to be able to keep updating the tool and integrating feedback from users on how the tool can be better. Sorry. Thank you. So some of the challenges in doing this work included feedback specific to where we see a lot of variability in the level of effectiveness across interventions. So what we heard a lot from our stakeholders is that having this evidence is a wonderful thing, but what do we do in the face of conflicting evidence? So there's conflicting estimates within sort of a suite of studies that are looking at one intervention specifically. So we heard a lot of feedback, and potentially what our next sort of phase of this work is to better understand how we interpret those effect estimates in the context in which these interventions are implemented. We do know that it's very important to highlight the variability in the effectiveness of interventions when making decisions, or that's what we heard from our stakeholders, is that they like to know if there's, for example, different strata reported within each of these interventions. So does this intervention work across different age groups or different populations? They really wanted to know that information to be able to make those kind of decisions. We learned that we don't have enough information on the specific role that evidence plays in the decision-making process. And then again, that's sort of part of our future work, is to better understand how evidence plays in that decision-making process, particularly for public health practitioners. And we also learned that context in implementation of built environment interventions is really everything. And we really need to do some more work in this area to specifically know how to best support built environment change using evidence-based interventions. So very quickly, just switching gears to the infographic. So this is, again, back to the 3 objectives included in CHASE. We collected data across all 3. And what we thought was really important to do is to provide our local practitioners with summaries of the evidence across all 3 objectives. And what we heard from them was that putting it in an infographic would be very useful to them. And so we have collision data from the first objective That includes Toronto, Peel, Calgary, Vancouver, and Montreal. We have active transportation data from all of those cities, plus Laval and Surrey. They came along for the ride. And we also have qualitative data from Objective 3, which I will not steal Dr. McCullough's thunder later this afternoon to present all of that information to you in her presentation. But we wanted to better understand in Objective 3, what are facilitators and barriers to the process of implementing BE change? So this is a screenshot of the infographic. I've broken it down into pieces because it's a little bit long to show on one screen. But as you can see here, sorry, that's very small. But as you almost can see here, there's a bit of information on the active transport piece. So right at the top, we give our sort of operational definition of active school transport, and we report, in this case, for the City of Toronto, what their proportion of active transportation that was observed in the schools as part of the first objective of CHASE. So for Toronto, there was, I can't even see it myself. Is that 86%? of children were observed walking to school in the schools surveyed in the City of Toronto, and that ranged anywhere from 24% in some schools all the way up to 99% in other schools. We also included information on what factors increase or decrease active transportation. And here we decided, and again, from feedback from our stakeholders, was that they wanted to see the results for their municipality in the context of all other cities participating in CHASE. And so we have the results of that manuscript that was published by Dr. Linda Rothman that shows all cities' associations with AST increases or decreases in AST, as well as the results specific to Toronto. We also provided collision data. So this is pedestrian and cyclist motor vehicle collisions in the City of Toronto. And we've overlaid the collision heat map data on with the observational study. So the circles represent the schools and the proportion of AST in each of those schools. The white circles representing schools with lower proportions of AST, with the darker circles representing schools that had higher proportions of AST. And the heat map, or the density map there, you can see where areas of higher collisions are marked in yellow, with the dispersion or less dense areas of collisions in the purple and blue areas. We also included information on what factors increase or decrease collisions. And so again, we incorporated the results of this study, again by Dr. Linda Rothman, into an all cities result, as well as in the context of those specific to the City of Toronto. And finally, that Objective 3 data, where we looked at facilitators and barriers to the process of implementing BE change. And these results were specific to Toronto. So what their local practitioners cited as facilitators and barriers to the process of implementing BE change. So some of the challenges in doing this work was overwhelmingly, we heard from our local practitioners that the results that seem sort of counterintuitive to what we already know or our current understanding of factors that are associated with collisions and active transport were difficult to navigate. And these are actually not finalized. They're in their final form, but we haven't released them yet. And so we're still working with the practitioners to better understand, what do we do with those results? And how do we inform those who are going to use the infographics as an opportunity as a communication tool? So if they see a result that seems, again, counterintuitive to what we know, it's a bit of a conversation starter with those who are using the infographic. And of course, we really want to evaluate these. So we're going to be collecting information when we give these to our practitioners to better understand how we can use them in the future. So what we do know is key to the development of any program of public health is to use an evidence-informed decision-making process. But to do this, of course, there's a need for accessible evidence on intervention effectiveness, as well as access to local data that can help inform programs for road safety. Thank you very much for your time, and I'm happy to take any questions.
I was just wondering, maybe you can't tell us this, but do you have an example of an intervention where you found like mixed evidence? in the literature?
Yeah, there was a few, and speed humps was actually one of those interventions that had mixed evidence. Pedestrian countdown signals is also actually an area that has quite a few publications on examining the effectiveness of PCS. I had the opportunity to examine PCS in Toronto, so we've published on not only pedestrian collisions, but also car-car collisions with PCS. And really what we sort of learned from that is that it's not necessarily that you would say, for example, to use PCS, pedestrian countdown signals, it's not that PCS don't work. It's the fact that when PCS is implemented in different contexts, we need to think about those contexts in which they're implemented and make adjustments according to that context. So for example, if the crossing time needs to be longer because it's in a community safety zone where there's a lot of older adults, for example, we might need to increase the time allocated to the PCS to allow for a safer crossing. Thanks, everybody.
Good. Sure.
Okay. So for our final speaker for this morning, we have Michael Branion-Calles. If I pronounce that correctly.
It's okay.
Michael is a postdoctoral research fellow at the University of British Columbia. He is interested in using geographical and/or epidemiological approaches and novel data sets to answer applied questions at the intersection of transportation, safety, and health. Welcome, Michael.
Thanks. Hi. So today I'm actually presenting on behalf of Neil Arison. Neil, I have a joint position at the BC Ministry of Health and at the University of British Columbia. So part of my time is dedicated to working on Ministry of Health initiatives and injury prevention. And one of the projects that I had the opportunity to contribute to is this Vision Zero Road Safety Grant Program. And so Neil can't be here today. And so I will try my best to fill his shoes. I find Neil to be a very good public speaker, and he's very passionate, enthusiastic, and I've been told by my students that I should care more about the things I talk about. So I apologize in advance for the monotone. Okay. So with regards to transportation injury, there's various concerns that the Ministry of Health has, obviously, that injury comes into play. So transportation-related injuries cost the BC healthcare system a tremendous amount of money. As if you were here on Sunday, Dr. Pike presented on the economic costs and the direct costs to the healthcare system. And as well, there are inequities in injury outcomes. For example, child pedestrian deaths, low-income families and Indigenous children are overrepresented. People in the lowest employment quintile are 7 times more likely to die of a transport-related injury than those in the highest quintile. And transportation deaths have a disproportionate impact on young people as well. So within the Ministry of Health's Injury Prevention Strategic Framework and Action Plan, Vision Zero has become a program component that's pretty important going forward. And obviously as well, active transportation is healthy for you, and it's a pathway for improving public health. And so we want to make these things safe and have as little injuries as we possibly can. So Vision Zero, I'm sure many of you are familiar with the concept, but essentially is the idea that no one should be killed or seriously injured in traffic, that making a mistake shouldn't cost you your life or someone else's life. So it's a framework for implementing policies and interventions to improve society and reduce injury and death and all of the misery that comes with injuries from motor vehicle collisions or active transportation injuries. So it started in Netherlands and Sweden in the 1990s. Sweden enshrined it in law. The European Commission has adopted the goal of moving towards zero fatalities in road transport by 2050. And a number of jurisdictions around the world have adopted similar visions and targets. So in the Netherlands, the road crash fatality rate in the 1970s was 24.6 persons killed per 100,000, compared to just 4 in 2011. So there is some notion that Vision Zero is sort of pie in the sky, that it's unreasonable and kind of idealistic, but other jurisdictions have made it work and have significantly improved outcomes in these areas. So for example, this is an interactive map called DECRA, where they highlight all of the different cities that have had at least 1 year of zero fatalities in the past 10 years, I think it is. There's hundreds of cities with populations 50,000 plus that have achieved zero fatalities in 1 or more years across the globe. And just to further drive home this point, as I think Neil would really like me to do, so there's 2 European capitals, Helsinki and Oslo, that have achieved zero pedestrian and cyclist deaths recently in 2019. In Norway, there's zero child road deaths in that year. In Oslo, there was only 1 car driver death. And in Helsinki, there was 1 car driver and 2 motorcycle deaths. So all of this just to say that very low numbers of the worst possible outcomes. And as a part of how they did this is that they both cite speed reduction as being critical to their Vision Zero. And Helsinki has made their city center mostly a 30-kilometer-an-hour zone. And in residential areas, there's speed bumps, elevated pedestrian crossings, and roundabouts. So this is all just Vision Zero context in general. And so in BC and with the Ministry of Health, as a part of this vision, there's a program that has been started called the Vision Zero Granting Program, which is providing funding for regional health authorities to directly support road safety improvements in communities with a specific focus on vulnerable road users. So the entities or the organizations that can apply for these grants are local governments, Indigenous governments, and NGOs. Each health authority got around $100,000 to distribute to applicants from the various organizations. And the funding came from the Ministry of Health, the Ministry of Transportation and Infrastructure, and Vancouver Coastal Health. So there's 2 streams in this granting program. Stream number 1 is for sort of general stream that any of these organizations could apply. So the idea was to design and install innovative low-cost road improvements, so within about $20,000 or less, temporary or permanent, primarily in smaller, remote, and disadvantaged communities And then stream number 2 was designed specifically for Indigenous communities in keeping with the BC government's commitment to a government-to-government relationship, meaning that in this stream, Indigenous communities set and direct their own road safety priorities. So just as an example of low-cost road safety improvements, things like traffic calming curbs, reduce speeds through signage, leading pedestrian intervals, or rectangular rapid flashing beacons. All of these things are within the range of a single grant. I think Neil verified these costs through somebody he knows. I hope he's right. I can't vouch for it myself. And as well, here's some other ones as well. So all of these sort of low cost, generally sort of easy to implement interventions. Oh, I already covered that. So here's an example of a project that wasn't, or a grant that wasn't in this year's or in the broader Vision Zero grant that I'm talking about, but was implemented in earlier iteration through Vancouver Coastal Health, which was the same idea, small seed grants for road safety interventions. So the Aucoin, I hope I'm pronouncing that right, I'm probably not, on the Central Coast is a small remote Indigenous community. They had a tragic incident that kind of spurred a local movement to a tragic road safety incident that spurred a local movement to kind of for community members to take matters into their own hands and post different signs, because it was recognized that the lack of signage and adherence to sort of road safety or to speeding laws was a big issue. So a group of community members came together to increase road safety by posting safety signs and trying to increase overall community awareness. And then they were encouraged to apply for a Vision Zero seed grant through Vancouver Coastal Health, which is very similar to what we're doing at a provincial level now. So the idea was to increase road safety through the seed grant through a collaborative and culturally appropriate approach. The community identified key locations to post speed limit and stop signs, the absence of which was identified as a prime reason for speeding and collisions. Through the seed grant money, they ordered and shipped 30 stop signs and traffic signs to enforce a community speed limit of 15 kilometers an hour. The signs were bilingual in English and the Aucoin language. And children in the community also designed signs promoting road safety and awareness. It can be seen here that are really cute. Oops. And so the grant sort of enabled a multi-pronged and community-based approach to address road safety, and also led to the development of the first ever First Nations chapter of Mothers Against Drunk Driving. And there was also a community taxi service offered on Friday night as a result of this program. And so that is sort of the program that's already been conducted and now sort of been scaled up to a provincial level. So in this year, the first year's cycle of this program at a provincial level, 75% of the organizations who applied for a grant were approved. 100% of the Indigenous communities who applied were approved. Successful grants included proposals to improve crosswalk safety at elementary schools, highway speed feedback signs, reduce speed zones, rapid rectangular flashing beacons at crosswalks, improved road safety signage, and support for separated multi-use paths along the highway. That's just one project actually, but 37 grants were funded in the current cycle. It's kind of hard to see, but 6 grants in Vancouver Island Health Authority, 5 in Northern Health, 11 in Fraser, 10 in Vancouver Coastal Health, and 5 in the interior. Of the 37 funded initiatives, 16 are from Indigenous communities. So $150,000 can fund safety improvements in 10 Indigenous or local communities. 10 communities are one step closer to zero road-related fatalities and serious injuries. And that's it. So thanks. If you have any questions, direct them to Neil. So.
Thank you so much for that. Were you involved in like the adjudication processes or anything?
No, my role was very limited. So yeah, I've been working on like a modeling thing for the, the project. So
Yeah.
the actual adjudication I wasn't involved in.
Okay, cool. Thanks.
Michael,
Hi,
thanks for the presentation. You talked about the fact that this is funded by Health and Ministry of Transport and Infrastructure. Do you know if there are any plans to widen the scope and invite other funders to participate in this program? Is there private sector contemplation, for example?
I don't know that, but that's a good idea. I mean, more money would be better, I think. You can agree.
Thank you.
All right, thanks.